today. Welcome to Egypt. And today my talk is going to be very simple for my young colleagues. We all know the line and stages and zones, but how we're going to see it, how we're going to approach for this young baby who's crying in the NICU. Okay, we're going to start when and how to examine. Okay, retinopathy prematurity is a leading cause of preventable childhood blindness worldwide, and actually it's not just preventable, it's screenable, predictable, and treatable. So if we miss a child to reach for stage 4 or 5, it's going to be our mistake, because we are the first line against this war for the ROP. It's a proliferative vector retinopathy affecting preterm infant, and before we go over when and how, we need to know why we're going to screen these babies. We're going to screen these babies because ROP kids are coming, and the numbers are getting more and more because the preterm survivor is increasing globally, because the healthcare system is getting better and better, and they are aiming to make this baby survive. They are aiming to make this baby survive and live, but sometimes because of the shortage of knowledge of the effect of oxygen and uncontrolled oxygen, this baby may live but with disability and complications. Especially in somewhere like Egypt, we are a developing country, we are trying to having increased number of neonatal units. Everybody is donating for neonatal units, and also doctors are fighting for making this baby live, and we have increasing risk with ROP. So we should be all prepared to be a screeners. Also, ophthalmologists, we don't make it a subspecialty. We need to fight this as much as we can, because as we said, as Dr. Ahmed said, we have now biomarkers, we can predict it, so we can stop it. And this is our rule, because you don't want to see it. If you see it one day, you're gonna feel very, very ruined and very upset. This is our fault to have a baby like this. In most of the cases, this is our mistake and our delay of screening. Okay, which baby you're going to screen? If I'm having an incubator with 40 babies, I'm not going to screen all of them because it's a burden for the baby. We're going to have some babies, and we're going to select high-risk infants. We don't have our data. That's most of the time we don't apply US or America's data. We use India's. So we have this guidelines going after the steps of India's guidelines. We have birth weight less than 2 kilos, and gestational is 34 weeks or less. And we also have selected cases that we should, if they are twin or triplets, if they have septicemia, blood transfusion, any illness, any severe illness, and actually also on demand of the pediatrician. Sometimes he told me, please examine this baby, he had so multiple oxygen, he was on CPAP, then on a vent, then on CPAP again, and they know the risk of uncontrolled oxygen, but because we don't have something called oxygen blenders, that's why they know the risk. They asked me to please examine this baby. And this is the collection slide for how the risk factors that which babies you're going to select and which baby you're going to examine. And this is a little bit higher than UK and America, because we don't want to miss any single child. To make it very simple and very easy, 28 days after birth. 4 weeks. Most of the time, you have a baby. It's 10 days. It's 20 days. No, it's not gonna. We're gonna not detect the illness right now. We need to wait till. And the most make it as simple as basic as this. Okay, you need when you start to examine, you need to be ready. You need to go to everything handy. Everything is available in your hand. You need to make it as fast as you can, as efficient as you can. You need to make it sterile as much as possible. You don't make cross contamination between babies. If you have to examine so many babies in the same incubator, prepare the size that you can examine. I'm going to show you now clinically how I'm doing by myself. We hand washing between babies. Check if the pupil is dilated. To check it by yourself. Don't just depend on your assistant, on your nurse, because if it's not fully dilated, this is a bad sign. You need to be very, very aware that this baby is not very well dilated. Both the drops, if you can, put it by yourself. Wipe the extra drops on the cheeks. Monitor the vital signs. If it's inside the NICU, you can check the monitor or ask the pediatrician to check for his vital signs. If it's out, it's a good sign for the baby to cry while examination, because if the baby stops crying, you're going to cry by yourself. Examine in a systemic way. Start with the right eye, then the left eye, and when you start with the right eye, you first start with the posterior border, check for the zone 1, and then you go to the periphery, temporally, and then nasally, and then to the oral data. You examine 360 degrees to determine in which zone is the most severe illness and most severe stage. where to examine. You can do it in the NICUs or you can do it in the outpatient clinic. There's a mistake here I want to point, and we're not wearing a gown, and this is wrong. It's better to wear a gown. There's a gown for every single NICU. You can put it on. You don't want to have any burden of infection for these babies. You are already vulnerable. How to examine, please try to remember these very simple steps. They are very simple steps. Dilate, swaddle, prepare your tools, and stand on the patient head correctly so to make it efficient and rapid and fast as much as you can. Dilate. How I'm going to dilate this baby? There are so many series. I'm actually attached with one of them. I'm having 1 centimeter of cyclosporine added to mitriacil or octotrup or any tropicamide. It's better to be 50 or 0.5%. And try to maximize. This is a photo of the big eye photos. The very famous photo. This is to tell you try to make it as much as dilated as much as you can, not half dilated. Use a pain relief, don't forget about it. And also control the ocular dryness, because if you take so much time, you will have a little bit of dry eye, and it's going to make you a little bit difficult to see the posterior segment go. Okay, and prevent everything. I'm going to show you right now how to make it. Dilating the eye drops is sufficient to allow adequate examination of the fundi, but not so excessive, because sometimes it's having side effect on the cardiovascular, cardiovascular system, on the GIT. It's very common for this baby to vomit, and you need to tell the nurse, take care if he vomits, because he can suffocate if nobody is paying attention for him. Swaddle. I'm going to show you now how to swaddle a baby very efficiently and very effectively, so you can control him, so you can provide him from hypothermia, because most of the time there is, if he's an outpatient, there is an AC on to comfort him, and if there's a pacifier or something to put in his mouth, like even the pacifier is going to be good for him to be warm and comfortable. This is how you make the swaddle. I'm going to show you now on a doll. Tools, prepare everything to make it handy with you. This is all the tools that you need. It's not that hard. It's very simple, very easy. Then you can find it anywhere you're working at. The gold standard is the indirect ophthalmoscopy, the indenture, the 3 volt lens or 28, and also the specular. Make it easy for you. Prepare yourself very well to make it as fast as you can and most efficient as you can with no burden on the baby. This is size of the indenture. You can use any of them. Position. I'm going to show you actually on a table right now, so you can feel it correctly and properly. This is a table showing how to, based on the gestational age, but again, to make it very simple for every young doctor, is 28 days post delivery. Okay, and this is the follow-up examination. After you finish your examination, you're going to put him in which of these stages, and then you're going to tell him when to examine him, 1 week or less, up till 2-3 weeks. And the first important and last thing is document what you see. Document for yourself, document for the patient, document for the parents, and also document where the second visit is going to be, and you need to consult the parents very well. I'm going to see you after 1 week in 9 a.m. And it's also, I'm having here with me a document that they are signing in, so if they are missed or something happens, it's going to be their fault. We're not going to be to be against the law. We have hand-drawn sketches, or if you are rich, you can use the digital imaging using the RedCam, which is not, it's very important for documentation. But if you don't have it, you can still be a screener. Don't stop it. It's not. Yeah, you don't stop the project for this. Okay, thank you for now. But allow me to show you how to. Okay, I'm having this little 4-year-old baby. Okay. If you want to come, if young people want to come, they can approach me if they want to. First, I'm having this one for documentation. This is for me. This is a hard paper, it's not a nice one. I'm having in the consent that you need to come and examine when I need you, and sign with the الرقم القومي, because لما أقول لك أكتب الرقم القومي هتبقى paying more attention. Okay, I'm having everything reachy because this baby is crying. I'm having my indirect is on. I'm it's charged. I'm having my binocs, I'm having my artificial tears, I'm having my combination. 1 centimeter of this adding to this is very nice without any side effect as much as we can. Don't forget to be sterilized, everything is sterilized. You can use this for indentation. We are doing a little bit rolling more than indentation. You have your speculums, but by the way, if you bought it, it's very common, you can lose it. Try to make it in a safe place, in a box like this, because you lose it and you're going to buy it again, one more. You don't have any burden. By the way, this one is preservative free. This is very good. I'm trying to have the best for them, the preservative free, the minute. I'm going to show you now how to make it in the swaddle. Just any cheese. If they don't have it, this one is from the OR. from my hospital. One second. Sorry. Okay, don't forget the baby's crying. You need to make it as fast as you can. Because when you do it very good, he's going to control him and you're going to be able to see it very good. This side is the end under the baby, and this side here, like a sandwich. Now, I'm very controlling him, I'm controlling his head. Validate everything first, putting the Minox. Last thing to put in the eye, and the first thing to take up from his eyes. Okay, the position. I'm now talking about the position. I'm going to move myself or move the baby. If the baby is fixed, I'm going to stand on just perpendicular in his hand like this. And once I put it in this position, I'm going to see zone 1. I'm going to see the macula and the desk. And then I'm going to shift myself crisscross. This way I'm going to see the temporal retina. Okay? And exactly in the same eye. Start with the right eye, and then I'm going to go again in the left eye. Be cautious, don't hurt the cornea because the cornea is scratched. You're not going to get this posterior signal. And then you're going to see the other eye the same way. You're going to put it directly in this way, but even if you're going to see zone 1, and then you're going to move yourself crisscross to see the temporal retina. Or you can stay the way you are. You can move the baby like this, and you're going to see the left eye or to see the right eye. And voila. Thank you.